And let's think about a pain pathway that begins in the skin. So here we have the top layer of skin, and underneath this we have the lower layer of skin there. So the top layer of the skin, as you probably know, is the epidermis, and the lower layer of skin is the dermis. Now the epidermis is fairly compact keratinocytes, the skin cells, but the dermis is what contains the most of the sensory endings. There are a few light touch sensory nerve endings in the epidermis, but the vast majority of the tactility from the skin is coming from the dermis, and that certainly includes the pain receptors. So throughout the dermis there are branched pain receptors, like this, branching through the dermis. And these pain receptors are called nociceptors. Nocere is the Latin for to injure. So nociceptors, from the Latin to injure. Now, pain is generated by these nociceptors, and it's very clever because the pain is generated at the point at which these tissues are about to become damaged or have just become damaged. So at the point when the tissues are sufficiently burnt or mechanically distorted or whatever it is, where an injury is about to occur, the nociceptors will generate a new nerve impulse. And that new nerve impulse will go off towards the central nervous system in a sensory neuron. And that will go off towards the cell body of the sensory neuron, just here, and then that will go off down into the spinal cord, and there it will terminate. Now, the nerve fibre here, this is the dendrite. Now, why is this the dendrite? Because a dendrite is any nerve fibre. This is a microscopic nerve fibre. This could be in a nerve of 20 or 30,000 other nerve fibres. So the impulse is generated here. This is where the impulse is generated by the nociceptors, the peripheral sensory receptors, process called transduction. And they send the nerve impulse up here, up the dendrite of the sensory neuron, towards the cell body of the sensory neuron. So the impulse goes to the cell body of the sensory neuron along the dendrite. Now, very often these sensory neurons have a myelin sheath with the Schwann cells, individual Schwann cells, wrapping themselves around the, in this case, the dendrite of the sensory neuron, forming this fatty myelin sheath, which protects, insulates, nourishes the nerve fibre, and also facilitates much more rapid transmission of the nerve impulse. So what we've actually drawn here is a fibre called an A-delta fibre, A-delta myelinated fibre, probably transmitting the impulse very quickly at about 30 meters per second from the periphery along the dendrite to the cell body. Then from the cell body, the impulse goes down the axon. So this is the axon of the sensory neuron, and an axon is any nerve fibre carrying an impulse away from the cell body. So it's nociceptor, dendrite, cell body onto the axon. And the axon goes into the spinal cord. So here we have a cross section of the spinal cord. And inside this there's an H-shaped area. Somewhat like that. And the H-shaped area contains the grey matter. that's the grey matter there of the spinal cord. So all this in here is the grey matter. The bit round about the outside, that's the white matter. This is the sensory neuron cell body, just there. Then the axon is going into the grey matter of the spinal cord. Now, the sensory impulses always go in the back. It's always a rear entry. This is the front down here. So always a posterior entry into the spinal cord. So this bit here, because these are shaped a bit like horns, that area here, where the axon of the sensory neuron is entering, is called the dorsal horn. So the axon of the sensory neuron enters this area here, which is the dorsal horn of the spinal cord. Now, very often there's a small neuron here, very short one, an interneuron or a relay neuron. So this would be a relay neuron, that very small one there. Just there is the relay neuron. And that's relaying the impulse from the axon of the neuron entering the dorsal horn just across the spinal cord a little bit. And we'll see later on that that's important for modulation of the pain impulse. And we also notice that between the axon there and the relay neuron there's a small gap. Small gaps between nerves you might know as synapses. So that is a synapse. Then there's another synapse here before the next neuron starts, and this neuron goes across the spinal cord like this. And it goes out of the grey matter of this anterior horn into the white matter. So the impulse is going to go from that neuron there, across that synapse. Now here the impulse is electrical. Here the impulse is chemical across the synapse. Then across that second synapse there as well. So the impulse is now going this way. And we notice that the impulse has now gone across the spinal cord. Because it's always one side of the body that feels the other side. So if this is the back, that would make that the right hand side of the body, wouldn't it? And it goes across the spinal cord. Process called decussation. The synapses use chemical transmitters, which become important when we consider pharmacology. So the fast myelinated A delta fibres, their main chemical transmitter is glutamate. But there's also achy pains as well, transmitted by fibres which aren't myelinated, which we haven't drawn, but if you imagine this without the myelin sheath. In that case it would be a C fibre, and they transmit the achy pains as opposed to the sharp pains. And the C fibres, their chemical transmitter is usually a substance P, so short polypeptide. P stands for polypeptide or protein. So the impulse is now across here on the opposite side. And this is at a particular level of the spinal cord. So to get to the brain, I think you can probably see that the impulse has got to go up to get to the brain. It's got to go up the way. So what will happen now, just move these out of the way. What will happen now is that the impulse will have to go up the spinal cord. So that's across in one plane. So it's as if it's going up the way like that in that plane, straight up towards the brain. So that goes up the way like that. This goes up the spinal cord. And the neuron that goes up is an ascending neuron. So we're now going up in an ascending neuron. It's going up the way. An ascending neuron. Now, this neuron is going to go up now towards the brain. And it's going to go up on the same side, and then it's going to come to the brain stem. So here we have the brain stem, the lowest part of the brain is the brain stem. The bottom part of the brain. This is brain stem. Midbrain, pons, medulla oblongata. And it's going to go up this side of the brain stem. Then it's going to leave the brain stem, and it's going to go to an area near the base of the brain called the thalamus. It's going to go up to the thalamus. Then that nerve fibre is going to go into the thalamus, and in the thalamus that's going to terminate. That's the end of that one. So the impulse has now gone up the opposite side of the spinal. So the pain was generated there, it's gone up the opposite side of the spinal cord. It's gone up from the right side. So now this is now on the left side of the brain. There's two thalamic nuclei. There's one on the right and there's one on the left. So the impulse has gone up to the thalamus, up there. Now, because this tract here containing the ascending neuron, because it contains the ascending neuron, and it's going from the spinal cord up to the thalamus. So it's the spinothalamic neuron is going to be in the spinothalamic tract. And what happens is when this pain impulse reaches the thalamus generates a pain. So the thalamus generates a pain. So the pain and the suffering is actually generated by the thalamus. So here we need to move now. So here's the brain stem. Just there, the impulse is coming through the brain stem, up the spinothalamic tract, and it's gone to the thalamus. And the thalamus has generated a pain. And the neuron terminates there. So that's the same diagram. So we can see now that the pain has reached the thalamus, and the thalamus has generated the pain. So I've just transferred that diagram from there to there. So that's good, we now have a pain. And that's good because it's warning us that this tissue is being damaged. It's warning us it's being damaged. So whenever this tissue starts to be damaged, the nociceptors will reach what is called their depolarization threshold. They will depolarize and a new nerve impulse will be formed. But the new nerve impulses are all or nothing. It's an electrical impulse and it's always the same voltage. So if we have a little pain, it'll just generate a few impulses. If the tissues are being cut or burned with boiling water and there's a lot of tissue damage about to happen, it'll generate a lot of nerve impulses. That's called frequency coding. So how bad the pain is depends on how many times this impulse is getting up to the thalamus. So anyway, here we have the impulse has arrived up in the thalamus. And the impulse is in red, of course. It's arrived at the thalamus. If you like, one way to look at it is the pain is in red. I mean, it's not really a pain till it gets to the thalamus and it generates the pain. So now we have a pain, which is fine. We know there's tissue damage. But of course, we need to know where it is. We need to know where the pain is. So here on the outside of the brain, you might remember that if you're thinking about brains, we have the here's the brain here. Top part of the brain is the cerebrum. Then we have the brainstem just there and the cerebellum behind. And the spinal cord is continuous with the brainstem. And here we have the frontal lobe and here we have the parietal lobe. And everything we feel we feel just here the sensory strip, the sensory cortex, which is at the front of the parietal lobe of the brain. That's what tells us where things are happening in the body. So the impulses come up here to the thalamus. The thalamus will be around about here on this diagram. The impulses come up to the thalamus, gone to the thalamus. Thalamus generates the pain. But now we need to know where the pain is. So if we represent this strip here as a sensory cortex here, this is at the outside of the brain, this sensory cortex. Now what we have here is the body is represented here, so it's more represented more or less upside down. Hands would be here, feet will be down here. So the body is represented in the sensory cortex. So when you're feeling something, it's actually this sensory cortex that's generating that sensation of tactility. This sensory cortex here. The motor cortex, of course, is just in front. That's what generates the movement, the back of the frontal lobe. But we're thinking about the sensory cortex. So we've got a pain, but we need to know where that pain is. So that's our sensory cortex up there, which is fine. So we know where the body is. But this pain has to be connected with part of the body, otherwise we can't take effective action. So what happens is there's another neuron here, synapses with this one. Actually a little gap in there, there's a little synapse in there. Then this neuron here goes off to the relevant part of the body, off to this finger, for example. So if you like, the pain is sent from the thalamus where it's generated to the appropriate part of the body where the pain is experienced, and you can say, oh, I've got a pain in my finger. You know where it is. It localizes that pain. So that tract, taking the impulse from the thalamus to the relevant part of the body, is the thalamocortical neuron. So pain is localized by communication between the thalamus and the sensory cortex, localizing the noxious stimuli so we can take appropriate action. So you pull your hand away, stop it getting damaged. Now, this is interesting because this diagram also tells us where analgesics work. So aspirin and non-steroidal anti-inflammatory drugs work at the nociceptor level. So for example, inflammatory mediators will lower the depolarization threshold, but the aspirin and the non-steroidal drugs will inhibit the formation of the inflammatory mediators, which lower that threshold. They'll inhibit something called prostaglandin. It's the prostaglandin that sensitizes the neurons. So this will reduce that, working at this peripheral level. Local anesthetics are going to work on part of the nerve fibre. If you inject a local anaesthetic, lignocaine for example, that will block the dendrite of the sensory neuron. It will block the sodium channels. So that means the impulse can be generated there, but it can't get past. There's a blockage there. Local anaesthetics. Opiates and nitrous oxide work at the level of the spinal cord, but they also work up here in the brain as well. So they work there and up here in the brain. But they certainly work at the level of the spinal cord. And nitrous oxide works in a similar way to the opiates. At least part of its pharmacological action is that. Paracetamol is working up here in the brain somewhere. Paracetamol is centrally acting. Now here we've drawn the spinal cord, but the situation is fairly similar with pain in the face. For example, dental pain is transmitted to the brain via the trigeminal nerve, the fifth cranial nerve. And also that also crosses over, there's also decussation. The nerve fibres from your teeth, for example, cross over at the level of the brainstem. So pain in your right teeth is felt on the left-hand side of the brain. So this basic physiology actually gives us a lot of useful information. We understand the components of how the pain is generated and transmitted to the brain, and it also informs our understanding of the pharmacology of analgesia. So remember the basics of the pain pathway. Take these out of the way. Pain generated in the nociceptors, dendrite of the sensory neuron, cell body of the sensory neuron, axon of the sensory neuron, synapse with relay neuron, ascending neuron, up the spinothalamic tract to the thalamus. Pain is generated in the thalamus, but the pain can only be localized in part of the body via this thalamocortical neuron, telling us where the pain is.